Okay, do you see?
Yes.
Hello. We'll talk about conduction disturbance, but we can put everything under this umbrella bradycardia. By definition, by convention, bradycardia is when the heart rate is below 60 per minute. And because this is related with the physiology of the heart, specific with the electrical physiology of the heart, I will tell you a few things about this. What you see here maybe seems a little bit complicated, but look, the green one, you see my pointer or not? Do you see my pointer?
Yes.
Yes.
The green, light green one is ECG. It's obvious. No problem. It's written actually. And this is overlapping with the pressure recorded by cardiac catheterization. This is the green one is aortic pressure. The red one is the pressure in the left ventricle. Blue one in the left atrium. And you see, this is the atrial contraction mechanically. The pressure will increase and it's called A. After that is the opening of the aortic valve, the opening of the mitral valve. This is called isovolumetric contraction. This is called isovolumetric relaxation. Doesn't matter that much, but you can correlate the electrical activity with the mechanical one. And actually, you can see that the atrium is contracting sometime, it's starting here, sometime after the beginning of the electrical contraction. And the same is valid for the ventricle as well. This distance here is the time need for the polarization to reach the ventricle and to act like contraction. Okay, for this reason, for cardiac cycle, this Wigger diagram is very useful. A few words about the conduction system of the heart. I know that you know already, but just point a few things. We have an important sinoatrial node, which is near the orifice, the ostium of the superior vena cava. For this reason, it's called sino. Okay, the other one node is AV node between the atrium and ventricles, atria and ventricles. And what you see here are some atrial pathways through which the impulse come quicker from sinoatrial nodes to atrioventricular node. After that, it's his bundle, which is divided in left and right branch, sorry. And finally, Purkinje fibers, small. These are the most important two nodes, sinoatrial and atrioventricular. Usually, there are three natural pacemakers. One is what we know very well is the sinus rhythm. It's a sinoatrial node depolarization, which is usually between 60 and 100 per minute. Is the normal rate that you know, that the normal heart rate that you know. If this is not function proper, will intervene the next one, which is atrioventricular node, which is a pacemaker with 40 to 60 per minute, like heart rate. And if it's not working, intervene the third one. It's endoventricular rhythm. This usually is acting when there is a blockage between atrium, including atrioventricular node, and ventricle will be by themselves with this heart rate. How it spread the polarization, the impulse? It is burned in sinoatrial node. After that, will go through the atrium fibers between the right atrium and from specific fibers in the left atrium. till arrive in the atrioventricular node. And from here, it start to go first in the septum, and the septal activity is seen on ECG with a Q wave, a small Q wave that you can see normally in lateral leads usually. After that, you see the ECG downstairs, yeah? After that, it spreads in all ventricle and the QRS complex is completed. And finally, this is the repolarization period in which the heart, the muscle recover with the same loading, electrical load like before. If a patient have bradycardia, what problem can have? And you see, can be symptoms which are related with um, cerebral ischemia, because if it's bradycardic, less blood will go in all the body, including the brain. And this is syncope or less than syncope, dizziness, or confusion or memory problems, which are not permanent and are solved after solving the problem. You can have, the patient can have fatigue and shortness of breath because of decreased cardiac output, and finally can have chest pain because of decreased oxygen for the muscle, for myocardium, and headache because usually in this disease and in bradycardia, the systolic pressure tend to be higher. Why? And I will show you. There is a Frankenstein law, maybe you know about it, that says then that when the sarcoma, I mean the size of the ventricle, we can tell about size of the ventricle, it's increased, the force of the ventricle will increase till a certain value, of course. That means if, because the diastole will be longer, the ventricle will be better filled, and the force of the ventricle will be increased. And for this reason, the systolic output will be increased. And because of this increasing systolic output, the systolic pressure will be more than normal. Okay, that's explained. What about the causes of bradycardia? The most frequent cause is age, degeneration. In time, everything is it's working less good, and there is degeneration of a lot of tissues, or can be ischemia. Usually, in inferior wall ischemia, the conduction system is afflicted. Can be congenital. There are complete AV block congenital, and the patients are well enough till, let's say, 40, maybe 50 years of age, and after that start to have symptoms. Myocarditis gives heart failure, but can give blanc block or even atrioventricular blocks. Heart surgery or intervention, direct hurting of the conduction system. Hypothyroidism, usually it is associated with bradycardia. Increased potassium or calcium, potassium is more frequent. Obstructive sleep apnea, this is a um, new studied disease, and a lot of connection with heart failure, with fibrillation, and with bradycardia as well. Sometimes inflammatory disease like collagenous, like conjunctive tissue disease like lupus erythematosus or rheumatic fever. And drugs. Who knows which drugs can give bradycardia? Give me some examples, please.
Beta blockers?
Of course, beta blockers the most renowned example, but otherwise, except beta blockers, there are other drugs which are expected to induce bradycardia?
Digoxin?
Digoxin, yes, yes, can be. Digoxin acts by a vagal vagal activity. That means it's not a direct action, but it's indirect action. Okay, but it's correct. What else?
Cholinergics.
Cholinergics. Let me think about it. Yes, but we don't give cholinergics. For what for?
Oh, I thought you just meant in general, but I guess calcium channel blockers could be another one.
Yes, this is more frequent. Cholinergics, usually we have an intoxication or something like that, but poisoning. We don't have drugs to give usually. We give anticholinergic usually. Okay, and some antiarrhythmics drug like amiodarone, for instance. Okay, good. Let's go. What we need for diagnosis? It's very important the clinical examination. You don't find that much in the clinical exam, even though if you know about, probably you know, it's a renowned part of cardiology, Wenkebach blocks. Wenkebach was um, Austrian, I think, cardiologist, which described this without having electrocardiography, because described before invention of electrocardiography, only on clinical grounds. But usually you cannot tell very much, only if it's regular or irregular, how bradycardic is, but it's not very precise. It's more important to see if the patient has symptoms when is bradycardic. That you can have from the patient, from the anamnesis. But most important, and I put it with yellow, is electrocardiography. It's crucial. It's the most important exam investigation for defining exactly the type of bradycardia and sometimes the reasons of bradycardia. But if the electrocardiography is not enough, you can do a Holter monitoring. Holter monitoring is the same electrocardiography, but on 24 hours usually, maybe sometimes 48 or 72. These are recorded with electrodes which are uh, applied on the skin. Loop recorder. Loop recorder means like a halter, is as a halter, but it's for long time, month till 6 months. Usually it's implanted under the skin. Sometimes uh, it's applied on the skin, but mainly it's implanted under the skin. Exercise test. Why can be useful an exercise test? Let's say a patient have bradycardia and sinus bradycardia. You don't know if it's a disease or if it's constitutive for this patient, and you just put him to do some exercise. If the heart rate is adapted to the level of exercise, means it's constitutional and doesn't matter. If the patient has limited adaptation of heart rate and start to have dizziness because the heart rate cannot increase, probably it's pathological sinus bradycardia. Okay, what else? Tilt test. I'll show an image. That means it's a special test which elicits a vagal answer. And those patients which can have exaggerated vasovagal reflex will have a positive tilt test. Electrophysiology studies, these are the most precise, but are not on the large scale done. Most precise method. That means you record the electrical activity in the heart. And there are other examinations which can complete the study. Okay, about Holter, you see there are some electrodes which are applied on the skin and connected to a device which record the activity for 24, 48, 72 hours. Okay, and after that you read, because when you do an ECG, you just know what's happened in that minute. If you can cover 1 to 3 days, you have the chance to capture something which is transient, and it's useful. This is some kind of loop recorder which is applied on the skin, but this is less frequent. Usually it's a cutting and it is put under the skin. This is the tilt test. You see, the patient is laying on a table which can be tilted up. Usually it's a 60-degree angle for tilting, and we wait for an hour. In time, because of gravitation and accumulation of the blood in the legs, there are some reflexes in which patients which are hyper-responsive give a severe vasovagal response. And here you see a patient with a normal heart rate, and in time has actually asystole for a long period. I mean, few seconds seems very long, but are only few seconds. And after that, immediately when happened this, it is possible that the patient to lose conscience, and for this reason, it's strict. Actually, it's correct. It's not strict. It's tied on this table. There's some specific, like in mountain climbing. There are some I don't know, harnessings. Okay, and when the patient lose consciousness or is near losing conscience, the table is coming to the horizontal plane to uh, to speed recover the patient. It's not a problem. No patient has a severe problem. Only some of them are fainting, but most of the normal people have nothing at this investigation. Only those which are prone for faintness will do this reaction. Okay, and you can consider that if the reaction is positive, the patient has only vasovagal reaction like a cause for bradycardia. This is a lab in which somebody, a doctor, makes this, does these electrophysiologic studies. That means it's like the cath lab. Some of you probably saw the cath lab is similar actually, only there is something more than this cath lab. There's some device which record the electrical and give some impulses if it's need. But you see, this is with X-rays, and these are electrodes which are positioned in atrium or in AV near tricuspid valve to record the his activity and in the ventricle itself. And you see here how drawing would show what's happened upstairs and what happened. Record these activities, which is this is ECG. This is in the atrium, is and after that in the ventricle, and you can record when the impulse is given from the sinus node, how much it takes to go from the sinus node to the atrium, sinus atrium. You see, after that, how it spread in the atrium, how it's how much time passed the atrioventricular node, and finally when it's go in the ventricle itself. And for this, you can diagnose this better complex abnormalities, electrical abnormalities. Okay, we start speaking about sinus node, sinus bradycardia. You see, I pointed here, sinus node. Sinus bradycardia can have few causes. One is increased vagal tone, like vasovagal reflex, and this is common faintness that you can see and can happen. Maybe I don't know if you have seen or only you read or seen in movies when a young doctor pains when see blood or at a dissection or something like that. And this is because of increased vagal tone. It happens usually response at a pain or at the thought about a pain, for instance, in the stomatology. Okay, or can means something more important, like an acute myocardial infarction. Which territory of acute myocardial infarction usually is associated with conduction or rhythm disturbances? Do you know?
Inferior.
Inferior. Inferior is um, very close with this, associated with this conduction, or sometimes I don't know. Sometimes sinus problems, but it's usually transient. Carotid sinus syndrome. Do you know what is carotid sinus? Who knows? Okay, there is a small body which is a sensor actually, and it's situated at the carotid artery bifurcation in internal and external carotid, and when in different circumstances give a vagal reaction. When, for instance, it's very tachycardic, give a vagal reaction. But this body can be palpated from outside. That means when a patient with this hypersensitivity of carotid sinus is shave the beard, can have this reaction if it's very sensitive. This okay. Otherwise, other causes: infections, rheumatic fever, myocarditis, sleep apnea. I told you about this. Hypothermia. Hypothermia. It's usually the hypothermic patients are bradycardia and have this specific Osborne wave. Do you know what is Osborne wave?
J-point elevation.
Is exactly. It's usually a giant J wave. Sometimes the G point, which is a conventional thing, is more than a point, and we call it wave, J wave. But when it's very big, giant, usually we call it Osborne wave, and it's very tight associated with hypothermia. Okay, drugs. We discuss about drugs. Sixth sinus syndrome, and I wanted to arrive at this one because it's the most important pathological problem in the sinus level. Okay, let's speak about sixth sinus syndrome. Usually, there are few types of sixth sinus syndrome. One is inappropriate sinus bradycardia, like I told you before, a bradycardia which is not adapted to the level activity, and for this reason cannot increase proper the cardiac output, and the patient have dizziness and can faint actually. We or is normal heart rate but cannot adapt increase for the proper level activity, or it's sinus arrest. That means it's not forever, it's stopping of sinus impulse for a while, for a few seconds usually. Or sinoatrial block. That means it's a problem between the generation of the impulse in the sinus node and arriving in the atrium. And the most frequent is bradycardia tachycardia syndrome. That means on a base of bradycardic rhythm, the patient has very rapid rhythm, like atrial fibrillation, which are very symptomatic. But when the atrial fibrillation is converted to sinus rhythm again, will will be a long few seconds pause, and for this reason the patient can faint. And you cannot treat the tachycardia, which usually is annoying the patient, because the patient is baseline bradycardic, and you can increase the bradycardia. That's a dilemma in this case. I'll show a few ECGs. What is this? This is a sinus bradycardia. If you measure how many blocks, this is about 50%, 50 per minute. That means it's less than 60. It's a sinus bradycardia. It's a real sinus, you see. It's clear sinus, no problem with this. What is this? This is a sinus bradycardia as well. You see, 6, 8, 300 divided by 8, it's about 37, let's say, per minute, the base rhythm. But sometimes, after an premature atrial beat, there is a pause here. And after the pause, we don't see a P wave. Somebody knows what about this beat? What is? How, can you try? Okay, I will tell you. It's without P wave before, that means it's not sinus, it's not atrial. And it's the same morphology like the baseline. That means it's supraventricular, and actually it's a junctional beat. Junctional beat, which is coming because no atrial beat will come in the atrioventricular node. And finally is given this because atrioventricular node is a pacemaker as well. And if will not come any beat from the atrium, we'll continue with this read, which is junctional read. But in this case, the sinus recovered and started with this bradycardia, sinus bradycardia. Another case. This is with P wave before every beat, no problem. Still, the P wave is not sinus because it's negative in lead 2 and positive in AVF. That means the axis is different. Probably it's, we call it upper junctional beat because it's very close to the Kearns complex, the P wave. Okay, other case. What is here? It's a classical ECG. I showed you before. Who can tell me something about this ECG? Nobody? Okay. It's still an atrial rhythm, but it's not sinus because it's negative in lead 2 and positive in AVF. But the cause of this bradycardia and this bradycardic for sure, because even though we don't see that well, the grid, we can see that here has to be 60. That means it's about 40 something. But the cause is very clear because we see an inferior MI. We see the ST elevation in lead 2, 3 AVF, but in this case it's even more because you can see ST elevation in this 5 and 6. That means a lateral extension, and as well in V1, which means probably right ventricle infarction. And speaking about infarction, usually the minor changes are normal in high lateral leads like lead 1 and AVL, but not in precordial leads. And this ST depression is not mirroring the ST elevation, but instead means a posterior MI. That in this case, we're talking about infero, lateral, posterior MI, and right ventricular MI. Doesn't matter. This is the cause, and this is the bradycardia. atrial bradycardia in this case. Asystole. What means? The pulse, it's more or less normal, but it's irregular. After that, it's a long pause. Probably it's a till test as well. And here, probably it's a massage, chest, close chest massage, because you see uh, some waves which are not ECG waves. And here start to appear again the QS complex. It's a long pause. I don't know how much. Probably it's written somewhere, but I don't know exactly. Or you can catch on Holter. There are a lot of pauses which are not felt, are not felt by the patient. And you see here, it was recorded 3.6 seconds. Here, the patient doesn't feel or didn't feel too much. This is sinoatrial block. You see, there is no, these three leads are for width. These are changing 3, 3, 3, 3, but these three are only to see the read. And we can see, because the P is well seen, we can see that there is no P here, and actually this this distance is twice of normal PP or QS distance. That means it's a 2-to-1 sinoatrial block. In this case, you can see a drawing when it's blocked the impulse between sinus node and atrium. A means atrium. Okay. This is bradycardia tachycardia syndrome. You see on the bradycardic base rhythm, there are atrial fibrillation or other rapid breath, and when the conversion appear from atrial fibrillation to normal sinus rhythm, usually there is a pause which can decrease the cerebral output, and the patient can have syncope. We go to the next level, next node, which is AV node, atrioventricular node. And the problem here are called atrioventricular blocks. And in a word, speaking about first degree AV block means every P wave is conducted to the ventricles, but with a longer duration. You see, it's the PR interval is longer. Second degree, it is like that. Some beats are not conducted to the ventricle, and you see here one and here one. The difference between those two is that this is type 1, Mobitz 1, second degree AV block, and you see that the length of the PR interval, it's and cycles resume after the pause. The second degree Mobitz 2 AV block is with a blockage of a P wave without this lengthening of the PR interval. And finally, in in the third degree AV block, no P wave will be transmitted to the ventricle. And there is a more, okay, this is the one. Okay, in the second degree AV block, we include advanced AV block. That means more than one successive P waves are not transmitted to the ventricle. It's not the case here. I will show soon. What is this? Which kind of AV block is this one? You are there, or you are?
First degree.
Yes, first degree. It's easy. It's obvious. Usually has to be, let's say, one big block to be normal. Here is more than two blocks, and it's obvious first degree. Okay. This is the second degree type 1, that means Wenkebach. You see that the distance, look on for these two, which are this one, which is for rhythm. You see the P wave, the other P wave, which is blocked, and the distance it's smaller. It's actually measured 316. After that, increased 393, more increased 420 till a P it's completely blocked, and the circle start again. Okay, and this is a case from our clinic with Wenkebach. You see, this is the smaller PR interval. After that, it's longer, even longer, and the P is blocked here. And start with the smaller one and increase till one is blocked. This one probably here. Okay, and this show you with this scalar diagram what means blockage. I mean, A means P wave because it's atrial activity and it's obvious. AV node means AV node, and you see that this is the site in which the impulse is stopping. It's stopping, and V is ventricle. Okay, a P wave is not transmitted. Started again with short PR interval, longer, and blocked P wave. Okay, it's the same thing. This example is advanced AV block, which is considered the same second degree AV block. That means more than one P waves, you see here are two, are not transmitted to the ventricle. Usually it's a 2 to 1, you see one P is transmitted, one P is not transmitted, P transmitted, P not transmitted, and so on. Sometimes it's with Wenkebach, you see, it's transmitted a short period, after that short interval, after that longer interval, and one is blocked. But sometimes there are more than one P waves which are not transmitted, and we call high degree or advanced second degree AV block. What is this one? Okay, for differential diagnosis in AV block, second degree AV block, is this one, which is not actually AV block because this P wave is too premature here. It's actually a premature atrial beat, which is coming too early and is not transmitted to the ventricle. But it's not a problem of AV block. It's a problem of the conduction system is not recovered because the premature atrial beat is too early. But this you can differentiate from second degree AV block because the distance between P's is not the same. You see, here is the normal distance, the same here, but this is very small, and this is longer, as in premature atrial beat. Okay. You see here, it's a transient complete AV block. That means there is no problem with the normal sinus rate, with a normal heart rate, and suddenly no P wave, you see the P waves here, is transmitted to the ventricle. See, this is the most difficult type of block to be diagnosed because it's only a few seconds, a short period of time, and in this, the Holter is very important. Actually, this is a Holter recording. Okay, and finally, we arriving to the complete AV block. Complete AV block has few characteristics. One is bradycardia, because of course we're talking about ventricular rhythm. Second one, because it's ventricular rhythm, the QRS complex is enlarged. And you see here, it's like a right blunder branch block. Probably it's not a right blunder branch block, but it's an focus, which is from the left ventricle and has this appearance of right band block because the right ventricle will be stimulated later with a delay. Good. The third one, the rhythm is regular, more or less regular, because this rhythm is ventricular rhythm is irregular. This is not perfect valid in this case, and the most important thing, the P waves are not connected with the QRS complexes, and we see how chaotic is the relationship distance between P wave and QRS complex. There is no relationship between them, even though there are P waves. But sometimes, and actually in this case it's something peculiar, sometimes a P wave, if it's not a very severe destruction of the conduction system, if it's only a functional, I don't know, block, sometimes a P wave will be conducted to the ventricle, and this, in this case, P wave and the Kersh complex is a problem, see, because this is conducted by normal pathways and actually has a left branch block appearance, not the right one, like the other one. Okay, this is a proper complete AV block. You see the P waves are here, no relationship with the Kersh complexes, and the Kersh complexes are wide with right band branch block appearance as well. Probably the focus is in the left ventricle classical. Sometimes there is a complete heavy block, and you can see it is because it's bradycardic. It's 52, let's say, beats per minute, and there is no relationship between P waves and you can see here in this one, P waves and the Kersh complex. That means it's a total AV block. Still, the complex is narrow. This kind appear mainly when the escape rate is from the junction, from the atrioventricular node, and this happened mainly or in the lower part of atrioventricular node, mainly in the congenital total AV block. And the advantage of this narrow rate is that the heart rate is not that low, and there is a responsiveness to the neurohormonal impulses. That means when when the patient has activity, has a mild increase of the heart rate, even though it's ventricular rhythm, but it's from the AV node, in the lower part AV node, and the only part of the heart which are directly influenced, to say, directly controlled by the nervous and humoral system are sinoatrial node and atrioventricular node. In this case, because it's atrioventricular node, it's still some mild adaptation to the stress. In this case, we have a complete AV block because we have a regular rhythm. You see, it's regular with some wideness. I don't know if it's clear wide, that means 3 small blocks, but it's wider than normal probably. But we don't see any P waves because it's atrial fibrillation. But the fact that the rhythm is regular, these two are only artifacts. The rhythm is regular with atrial fibrillation means complete AV block. Comparative, this is atrial fibrillation with clearly enlarged, there's complex, but with irregular rhythm. And this for sure is not a complete AV block. It's only a low rate atrial fibrillation. You see, compare the distance from those two with the other one. It's clear irregular rhythm. And this is the is characteristic for atrial fibrillation. It is only low heart rate atrial fibrillation. It's not atrial fibrillation plus AV block. In this case, it's a very, very low cardiac heart rate. So heart rate, but we're talking about flutter at the atrial level. The treatment for those three, atrial fibrillation with AV block, low heart rate atrial fibrillation, or atrial flutter plus AV block is the same. It's implanted a pacemaker. Consequences of atrioventricular block: decrease heart output, because heart output is the systolic output multiplied by the heart rate. If the heart rate is decreased, of course, the heart the cardiac output will be decreased, and this can have symptoms of cerebral ischemia, like I told you before, confusion, syncope, myocardial ischemia, angina, or renal failure by pre-renal mechanism. That means decreased cardiac output. We have high blood pressure, only the systolic pressure. We can have malignant ventricular arrhythmias induced by the bradycardia, or even death by a systole itself or ventricular fibrillation induced by bradycardia. And the tachycardia induced by bradycardic rhythm. How we call this rhythm? Who knows?
Torsade du pont.
Exactly. If it's not the etiology of bradycardia, we call it polymorphic ventricular tachycardia. But if it's because of the increased QT interval, and this is related usually with bradycardia, we call it torsade de pont. And this is the case here. Treatment for bradycardic disorders. First of all, if you are near the patient, you have to stabilize the patient. Usually, if a patient has vagal reaction, you have to put this supine position and to give some blood. And if the heart rate remain low and the patient is symptomatic, to consider temporary pacemaker. After that, maybe it's some cause which is obvious and treatable, like hyperkalemia, inflammation, or ischemia. And if you treat this, usually the bradycardia is already gone. The most frequent etiology is ischemia. Usually, bradycardia, because of inferior myocardial infarction, is transient. We have to wait a few days for being sure that this is only transient and is not permanent. And after that, you can discharge safely the patient. Okay, drugs. You can give some drugs, atropine, or you can give beta receptor stimulation, or myofilin, theophylline is the same thing. If the bradycardia is severe, you have to implant a permanent pacemaker, and you have to treat the associated disorders. What about the cardiac pacemakers? Already, I think you know a lot of this, but what is essential? It's a small device. It's a small computer, let's say, which can treat bradycardic episodes, giving electric impulse, which is called usually spike, because on the ECG it's a line, it's very, very narrow. for starting myocardial contraction, and has two more main components: generator, which is replaceable, and few leads. Usually it's one, but can be two, or sometimes three leads, which connect the generator with different chambers from the heart. If it's only one, the most frequent chamber to be stimulated is the right ventricle. If are two, usually it's atrial, right atrium, and the right ventricle. If are three, it's plus a lead which is put in coronary sinus for stimulating the left ventricle itself. Mostly the leads are endocardial. This is on only exceptional are put it epicardial. Usually when a patient has surgery and they put the pacemaker after the surgery. The pacemaker is not only a battery for giving spikes and stimulation, but record and analyze the cardiac rhythm. And actually, the pacemaker is giving a spike only when the native complex is missing. It is called by demand. There is a more advanced development of this pacemaker, which have another option to give a shock to the heart. It's called implantable cardiac defibrillator. It's a pacemaker, but with something else which can give a shock when the patient has a malignant arrhythmia. And this is a pacemaker. You see how big it is compared with stethoscope. And these are the leads, the tip of the leads actually. This is the most frequent, like an anchor, and it is fixed by the papillary muscle in the right ventricle. But sometimes when it's a very, I don't know, you cannot catch it near the muscle. There is something with a screw in the end, and you put in the myocardium itself. And this is a chest X-ray of a patient with a pacemaker, and you see here three leads. Yes, or two leads. How many are they? At least two. No, three. There are three. One, this one is on the apex of the right ventricle. This one is in the right atrium, and this you see a faint, a smaller one. It's in the coronary sinus. On the right side, we have implanted cardio defibrillator, which have a generator which is alike, is similar with this, but it's bigger. And there is here a coil, we call it. A coil is the part which gives the shock, actually. And the defibrillator can have pacemaker activity as well. Okay. There is a special code for knowing exactly how a pacemaker functions. And the code is composed by 5 letters. We don't speak about the fifth one, but let's speak about the first 4. The first one means in which chamber there is the stimulation. Can be 0 for none, but it's not the case. A for atrium, V for ventricle, or D for dual. That means atrial and ventricle. In which chamber is the sensor? Because we have to sense the normal activity to know when to give a spike. Okay, can be 0 for none, atrium, the same. And what is the response when the sensor sense a normal activity? The response is usually inhibition. That means if there is a ventricular activity, then the pacemaker won't give another shock, another another spike. Or sometimes it's triggered. That means sometimes you can associate the P wave, the atrial electrical activity, with stimulated ventricular activity, and when the sensor sense the P wave, gives a stimulus to the right ventricle, and will do this associated between P wave and ventricular stimulation. Or there is another option, the final one, the fourth letter, if there is a rate modulation. Rate modulation means adaptation of the rate according to the level of activity. That means will give the chance of the patient to can have some exercise. Otherwise, the patient will be with 60 per minute when he's sleeping or he's doing hard labor. You have to adapt. That's the normal and the modern way. Okay, you see here, usually it's put by subclavian vein. There is a right atrium lead, right ventricle lead, and this in the coronary sinus. This is only for the left ventricle. When you put an electrode in the left ventricle, in the coronary sinus, and for the left ventricle, we call it cardiac racing synchronization therapy, because synchronize the activity of the right and left ventricle and make the heart more efficient. This is valid only for the patient which have a left bundle branch block. That means the activity is a little bit chaotic. It's not synchronous contraction of the right and left ventricle. And this show you a patient, and this you see the smaller one is for the coronary sinus. And if you are attentive, you pay attention, you see that this coil means that this is not a regular pacemaker, but a defibrillator actually. What are the complications of the pacemakers? Bleeding, it happens in many cases, because usually this patient have defibrillation or other causes of anticoagulation and will bleed. Lead dislodgement, that means you have to put again the lead, otherwise will not stimulate it anymore. Infection can be a pocket infection, that means when you put under the skin, when you put the generator, or it can develop an infection on the lead in the heart. We call it endocarditis, even though it's not endocardiac layer, but it's on the lead itself, the catheter itself. Cardiac perforation, it happened in some cases, usually when it's because of right ventricular infarction, and you put a lead there, and you can go through the ventricular wall, but it's not frequent. And arrhythmias, you see here some kind of arrhythmias. One is because of dysfunction, because the pacemaker will not sense the normal activity, or sometimes it's reciprocating rhythm. That means the stimulated beat will stimulate the atrium, and this will stimulate again, will be something circular wave. Or decrease output, or by pacemaker dysfunction, or by fibrosis in time, or by dislodgement. And I'll show a few images. This is an infection on the site of implantation, and you see actually the skin is necrosing, and you see the generator from outside. Usually has to be under the skin. On the other hand, on the right hand, it's endocarditis on the lead, and this is a right ventricle. This is the vegetation, and after operation, because otherwise we cannot take out the leads by pulling, but we have to do operation. This is the vegetation itself on the lead. This is the lead. This is a reciprocating grid, but it's a little bit complicated and won't insist. This is a dysfunction, and you see these are spikes. Some of the spikes are not conducted. See here, and actually the patient, most of the time, is in his proper endoventricular rhythm, which is this one. Sometimes it happens to stimulate the pacemaker, those two beats, for instance. This is the patient with atrial flutter that we saw before. After simulation, you see the spike. Sometimes the spike is seen very well. Otherwise, in other cases, you don't see it that well. You see, the rhythm is with LBBB appearance. It's regular with the spike before. But the level, the atrial level remains the atrial flutter. That means there is still a risk of embolization, systemic embolization, and this patient has to receive anticoagulants. This is an atrial stimulation. You see after the spike, which is this one, it follows an atrial wave, a small atrial wave, because the atrial waves are small by rule. And after that, the ventricle is contracted by himself. This is an atrioventricular stimulation. The first spike determined here, you see the P wave, the second one, the Krebs complex. In this case, we speak about cardiac resynchronization. That means there is a lead in the right ventricle and one in the left ventricle. And actually, if you take a very good look, you see that this line is not continuous. It's a little bit different. And actually, there are two lines, one here and one up, because there are two stimulation, one in the right ventricle, the other one in the left one. In other cases, even though it's a stimulated rhythm, you don't see well or at all the spike, like here, only when enlarged Krebs complex, or here we don't see the spike, even though it's a pacemaker rhythm. Sometimes when the pacemaker is put for atrial fibrillation, low heart rate atrial fibrillation, you can have a combination of the native beats like this one or this one with stimulated beats like those with white Krebs complex. And because of this, sometimes can happen that a stimulation beat to come in the same moment with a normal beat and to have a fusion beat. This fusion beat is something between the wide Krebs complex and narrow Krebs complex because it's a fusion beat. This is the same, only in this case, it's only one beat or two beats which are stimulated. The rest of the time, the patient is working in his own rhythm, atrial fibrillation rhythm. Okay, that's all. Thank you. If you want to ask me something, please do it. Okay?
Thank you.
Thank you.
Doctor.
Can you send us the presentation on one
Have
of
a
our
nice
emails?
day. What?